What can you tell us in the radiation oncology field? What is new? What is impressive these times?
Right. So let me begin with a brief definition of what radiation oncology is and what it does in terms of treatment of cancer patients. So radiation oncology is the application of radiation to a predefined target. It doesn't matter where it is. It gives ionizing radiation, usually with the help of some treatment platforms with some machines, to control the tumor locally. So it performs a type of a treatment like the surgery does. So it's a local treatment strategy. And the major advances in terms of radiation is actually a lot. A lot has been done since the last 10 years. We have a lot of advances in computing sciences. So we have implemented very high quality and very smart computers for the planning of the tumor, for the planning of the treatments. We have very nice advances for the implementation of high radiologic evaluations, so we see better where we treat, and we have implemented to our treatments as well. And we have integrated all of those technologies together with the application of the treatments. So this is the major advance.
What kind of cancers need radiotherapy?
Well, this is a very broad question. Roughly, I can say all types of cancers. But obviously, the timing of radiation, the indication of radiation, the type and technique of radiation, the dose of the radiation, the expectancies of radiation, and the outcomes of radiation are totally different. And this is a topic of a lecture. But we can clearly say that mostly all of the cancers can be treated, obviously integrated with other treatments with radiation.
Can we talk about side effects of the radiation?
Yeah, obviously every treatment has side effects, but with the treatment outcomes, not the outcomes, but the technology implemented with our very nice machines, the major outcomes of these high technologies is the better tumor control with less toxicity. Radiation has toxicity like chemotherapy because it's not selective. So radiation, when we send the ionizing radiation to a target, to a cancer cell, it doesn't say that, well, I need to treat the cancer cell, but I don't need to make any harm to the normal cells. So this is how we do it with our very nice machines. And if we target the tumor better, the outcomes in terms of toxicity will be less. And that's what we see in our clinics as well. So this is not hypothetical. This is what we see in our daily practice.
About that, what is the most common type of cancer that patients bring to you?
Well, it depends in our expertise, but in our clinic, we do see a lot of lung cancer. We treat a lot of lung cancer. We do a lot of brain tumors. We do a lot of prostate cancers. But roughly, as I said before, we can treat all of the tumor types with radiation, obviously with different types of intentions.
I'm interested in the breast cancer because I know you have a very special technique that can equal one session can equal 6 weeks of radiotherapy. Can you please tell me about this?
Yeah. So this is a new trend. It is called partial breast irradiation. And it can be done with different techniques, but the main hypothesis behind it was in selected patients, obviously a less risky patients, in selected group of the patients who have breast conserving surgery, so we do not take the whole breast out, but only we take the tumor out. The recurrences, the local recurrences are within the cavity, within the tumor cavity, or the 2 centimeter
board
surrounding it.
Round.
And the hypothesis was, so what, we only treat that area and spare the excess amount of breast tissue so that the cosmetic outcomes will be better. And that has been tested in different treatments platforms. One is called intraoperative radiation therapy. So what we do is we go into the operating room with the breast surgeon, and as soon as the breast surgeon takes the tumor out from the breast, before closing it, we do the radiation in the operating room. So that's only one session radiation, and it's during the operating room. So with that radiation, you can delete the whole 6-week adjuvant radiation that we do in our patients. Obviously, this is done in highly selected patients, but that's, one of the major trends right now.
And the outcome?
Yeah, the outcomes, so there are 2 different outcomes. First outcome is the cancer outcomes. The cancer outcomes are more or less the same. So the local recurrences are usually the same compared with whole breast radiation. And the second outcome is the cosmetic outcome, because that is the only reason why we are performing breast conserving surgery to our patients. And very recently, like 2-3 weeks ago, the cosmetic outcomes were presented in our American meetings, and the cosmetic outcomes were the same as well. So I think it's a major progress in breast cancer treatments.
Nice. What can you tell me about ovarian cancer? Is something new these days for in treating ovarian cancer?
Well, radiation oncologists are not very interested in ovarian cancer. It's usually, we usually perform for palliative purposes for the patients who progress after multiple types of treatments, it's a broad tumor that is present in the abdomen. A local therapy like radiation is not very effective in the treatment of ovarian cancer. We do not regularly see ovarian cancer patients in our clinics.
Can radiotherapy skip a stage from surgery? Can replace the stage of surgery?
Yeah, I think that's a very nice question. I'm really very pleased that you brought up this question. Yes, actually surgery and radiation therapy, as I said before, are both local treatments. So they usually fight in the same area to control the tumor locally. And there is a new technology, there is a new treatment technique called radiosurgery. So it's a stereotactic radiation therapy, giving very high ablative doses to a very small targets in a very short period of time. They can be done either by dedicated treatment platforms like Cyberknife or with other linear accelerators, but with very high technology softwares and hardwares. And the outcomes are more or less the same. And we do this in the treatment of brain metastasis for a very long time. So not all of the brain metastases need surgery anymore. Obviously, we work with the neurosurgeons if there is a need for surgery before this, but we're doing this for a very long period of time, roughly around 15 to 20 years. Now it has started to be done in early stage lung cancer. Now we're doing it routinely for the patients who are not able to be operated because of their comorbidities. We call those patients as medical inoperable group of patients. But now trials are ongoing for the group who are medically operable as well. So probably 10 years later, I can say that surgical outcomes are the same with the radiosurgical outcomes. So there are ongoing trials looking for this. We are doing this in localized prostate cancer to avoid a radical prostatectomy. We do this with our Cyberknife machine. The outcomes are the same with less toxicity compared with surgery. We do this with liver metastasis. We do this with pelvic lymph node metastasis. So yes, we are doing a lot of radiosurgeries and competing with the surgeons.
Can you tell me more about Cyberknife?
So Cyberknife is a name of a brand. It's actually a dedicated radiosurgery platform, and it's the only dedicated radiosurgery platform within the market right now that can treat the whole body with radiation, with radiosurgery. Everything has started actually with Gamma-Knife. So Gamma-Knife was another machine, but it's another dedicated radiosurgery platform, but it can only treat whatever happens within the skull, within the head. But Cyberknife is the treatment platform that can perform radiosurgery to all areas, all targets within the body. And the major advantage of Cyberknife that actually it's a robot, and it's tracking the tumor. So, especially when we have a target within the body, except from the brain, it moves because the patient is breathing, there are the pulsation of the vessels, there is the gas transfer within the bowel. So irresponsible from any reasons, it moves. So the advantage of Cyberknife, and that is the only treatment platform in the field right now that tracks the tumor. So what we do with, we narrow the margins. We treat very, very small margins, and that definitely decreases the toxicity, which is a major outcome.
So it's not something invasive, because the Cyberknife, you hear knife, you think it's something invasive,
right,
but it's not.
So we always wanted to become surgeons, probably, as radiosurgeons. We are the surgeons without the knife.
Without the knife.
Yeah, without the anesthesia, without the blood. Yeah, so it's a non-invasive procedure. We can say 80% of our indications are for malignant tumors, so for cancers. But 20 to 30% of our indications are for benign lesions as well, especially intracranial, like intracranial meningiomas, schwannomas, sometimes hemangiomas. We can be treated with radiation as well. So we have some benign indications, but majorly it's malignant indications.
Okay. Does the radiotherapy somehow get involved with the immunotherapy?
Yeah, a lot of things have been done since the last 5 years. So what has been informed, what have we learned from the trials from radiation, that actually radiation is a sort of an immunotherapy. So we call radiation as an in situ vaccine, like we vaccine our child, for measles, for chickenpox, whatsoever. So what we understand from the trials, that radiation is actually a sort of a vaccine, because what it does, when it kills the tumor cells have DNAs all around the body. And what it does to the T cells that we have in our lymph node, it attracts the T cells, and the T cells are attracted by the DNAs that has been within the body because of the help of the radiation. And the surrounding T cells go and attack some other tumor targets that have the same DNA, which is the same tumor, which is the same antigen. So roughly, radiation is a sort of a immunotherapy. But what it does with the systemic immunotherapy drugs that the medical oncologists use, that they're really very synergistic. So it increases the effects of the immunotherapy. It increases the time period that you benefit from the treatment of immunotherapy, and it overcomes the resistance with the immunotherapy. So combination treatments are very popular right now. There are some ongoing trials and there are some published trials. We know that it really helps a lot in the treatment of lung cancer. It helps a lot with the treatment of brain metastasis, especially for melanoma. But probably in the next 20 years, there will be more and more papers that emphasizes the outcomes of this nice synergistic combination.
Before the actual treatment, what does a patient have to do to get the best diagnosed or best treatment advice?
Obviously, it doesn't mean that having nice machines or more expensive machines have better outcomes. So what we need to be sure that the relevant type of tumors are staged or diagnosed with relevant type of diagnostic tools. Sometimes an ultrasound, which is the cheapest, can be better in terms of compared with PET MR. So it's a major of expertise of everything. You have the good machines, but if you have the good team to work with it, this is the nice harmony. Yes, good diagnosis and good staging is the best way to start the treatment of a tumor, but it doesn't necessarily have to be the most expensive. It has to be the best harmonized. Every cancer has their own personality. And as we start to learn more and more information from their personality, we can personalize their treatment. So we can tailor their treatment. So that is called personalized cancer care. That's what we're doing right now. But that's a team approach. in 2019, it's very difficult to treat cancer with only doing one thing. So that's a major team approach. That is the major advantage, what we do in our hospital. We work as a team. So we try to do small and little treatments with less side effects, but we harmonize them together to have better outcomes, but very small toxicities. Because as now it is like it has started to become a chronic illness. So as the patients are living longer, we need to take care of the quality of life as well. I don't care if I live 3 months long, if I am spending those 3 months with the side effect of the treatments in the hospital, right? So we need to discuss those sort of things as well, and that is majorly an outcome of a team approach.
So you said something very interesting, that you would want to live in a hospital for 3 months with those side effects, but if you were, God forbid, to get a diagnosis like this, would you be scared seeing everything that you saw and being in this field?
Yeah, well, probably as I know more, I would be scared, but compared with 20 years ago, I would be happy. Like I would say that, well, I'm glad that I was not diagnosed 20 years ago, because I know that more things can be done with less effort and less side effects. And if I was diagnosed as having a cancer right now, probably I would not be afraid to be treated. The team and the group of doctors working under the same roof. This is the major point. Working under the same roof, meeting together every week regularly for me, my treatment, my diagnosis, my side effects, and with other patients, and working in harmony.
Can we say that this represents the evolution of medicine?
That's correct. I've been working in this hospital for 2.5 years. What we used to do when I was doing my fellowship in Harvard Medical School is the same thing that we're doing here in this hospital right now. There is not a major difference. The technology, the philosophy, the mentality is more or less the same. So I can clearly say that we have done a lot of things.